for research and development. We told we have antibiotics to use. What we have to produce and generate new antibiotics. So how many? It is not a money-making service. The thing is that no one is interested in creating any new antibiotics because they will introduce money, lakhs and lakhs of protein. Antibiotic will work for 1 year or 2 years, and third year will have the resistance, so the use will stop. Company will be in a loss. So what is to be done? Action plan has to take an initiative in this. They have to provide which will need from various countries. Economic case invest in the new medicine development, new technology, and this will help rising game. Leadership, unless and until leaders of the country are interested in pursuing. For this, strong political will, strong leadership and accountability, improved coordination and collaboration of different agencies, resource allocation, regulatory oversight, as well as concerted efforts to align policies as well as public sentiment with the development is very, very essential. Then there's again state action plan, which sir has already told about. State action plan for containment of antimicrobial resistance. Already Kerala, Madhya Pradesh, and Delhi, they have produced a state action. We are yet in the process of making one. The most important priority of National Action Plan is to ensure implementation of antimicrobial stewardship. And this is to be implemented in all the healthcare facilities. Now, the word stewardship means the careful and responsible management of something entrusted to one's care. So, this particular term was originally applied in healthcare setting as a tool for optimizing the antimicrobial use. Now, since then, it has been used in context of governance of the health sector as a whole, taking responsibility for the health and the well-being of population and guiding health systems at national and global level. Now, to begin with, antimicrobial stewardship does not work alone. For an antimicrobial stewardship to contribute to the healthcare system, it has to be accompanied by other pillars, which is infection prevention and control, medicine, and patient care. You can see a picture over here. Antimicrobial stewardship implementation requires availability of quality assured antibiotics. WHO essential medicine that should be used for ensuring what kind of antibiotic is being used. There has to be constant surveillance about the current AMR situation. And all these information, when contributed together, can help implementation of antimicrobial stewardship at healthcare facility level. And this is going to ensure equitable and quality healthcare for all the community. So to begin with, what is antimicrobial stewardship? It has a very nice definition. It says it is a coordinated intervention designed to improve, measure appropriate use of antimicrobial agents by promoting selection of optimal antimicrobial drug regimen, dose, duration of therapy, and route of administration. So how do you achieve this? For that, we have goals set. Promoting safe and effective economic and rational use of antibiotics by all the prescribers. Second, improving patient safety or outcome with reduction in infection rate, improving cure rate, minimizing unintended consequences of the antimicrobial use. Reducing antimicrobial resistance by ensuring the best empirical or specific treatment for the diseases, which is justified antibiotics. Reducing the spread of infection by multi-resistant organism, again that is infection prevention practices, and then reducing the overall healthcare cost. Once you achieve all this, reducing healthcare cost becomes feasible and possible. So the core element for the ALS program implementation in all the healthcare facilities. First, there has to be the healthcare facility management really interested in implementing ALS program because there is a lot of ALS also at this. Accountability and responsibility, ALS action, education and training, monitoring and surveillance, and reporting and feedback. The first point, leadership and commitment. So this requires providing financial and information technology resources for implementation of ALS program in a healthcare facility. There has to be a clear line of accountability between the chief executive, the clinical governors, drug and therapeutic committee, infection prevention and control committee, and the antimicrobial stewardship team. A multidisciplinary antimicrobial stewardship team needs to get established, and there has to be a clear-cut collaboration between the AMS team as well as the infection control team to implement the AMS program in the healthcare facility. So, what does antimicrobial stewardship actions and all involve? So, antimicrobial stewardship action involves first providing a policy, up-to-date treatment guidelines for the clinicians to use in their patient care. Second thing is providing antibiotic policy. Antibiotic like antimicrobial resistance pattern of your healthcare facility. This policy has to be made by in consultation with the microbiologist, the pharmacologist, the physician, the surgeon from the major department, and these policy needs to get revised every year with updation. AMS action also involves doing regular reviews and audits of what antibiotic is being used in the healthcare facility and look for any scope of improvement. Providing advice and feedback to all the prescribers is also one of the main important function of the antimicrobial stewardship team. Taking regular rounds, conducting AMS intervention in healthcare facility department, providing drug formulary with a list of approved antibiotics. So it is said that every healthcare facility needs to have its own list of drugs available. The drug formulary should be the same which is present in your policy. So you cannot have any antibiotic extra which is not been suggested in the antibiotic policy. Second, these formularies should be available in both OP and IV pharmacy of the institute. They should be also compliant with the National Essential List of Medicine antibiotic drug. Okay, so in that, if I'm saying that it means that your drug formulary or even your OP IV pharmacy should not have any irrational drug combinations. So you will have MR providing you all lot of antibiotic drug combinations which are absolutely irrational or have no benefit. But yet again, they are provided in the OP and IP pharmacy. If you are providing a drug formulary and maintaining the compliance to it, you can curtail the use of irrational antibiotic combinations as well. And most of all, for an antimicrobial stewardship activity, you need to have a very good IT resource facility because that will help us ensure AMS implementation. This is something already told by sir, ML classification. Your drug formulary can make sure these antibiotics are made available. According to WHO recommendation, every institute should be using antibiotics, among which 70% of antibiotics belong to access group. Okay, it is rather very difficult for India to follow because if you see the list of access groups, you will majority of the time find them resistant or very difficult to trust in. So you end up using watch groups. In India, the current scenarios where we are using majority of the watch group antibiotic rather than the access group. Third important core element of AMS intervention is providing. So when we say about educate everyone who is prescribing to the consumer, train the prescriber. We can train them by creating awareness regarding what is the resistance pattern going on or in the healthcare facility. We can educate the colleagues about appropriate use of antimicrobial, especially in relation to specialist area. Encourage patients and other colleagues to question the optimal dosing. This is something probably difficult, but yet again have to start somewhere. Questioning the suboptimal dosing and administration of antibiotics. And when it comes to the consumer, consumers are now well educated. They get a lot of information from the Google and ChatGPT. They end up using those information and start with the treatment or self-medication. So they are the ones who need to get targeted, and we have to provide them information regarding what is AMR, how to use rationally the antibiotics. So this is something that we did with Bharti. We started targeting the community for antimicrobial stewardship. So what we did is we have targeted, the graduates of MBA college, law college, engineering college, and we first what we did a gap survey and we tried to understand what knowledge do they have regarding the antibiotics. And after we got that, we train them and provide them, then we had a 30 minutes awareness session, and we started with some basic information. Like the first thing we tried to explain to them is what is the difference between bacteria, virus, and fungi and parasite. And we, of course, we asked them, do they know the names of antibiotics? So many of the students did tell us they knew what is azithromycin, they knew what is amoxiclavulinic acid, they knew what is augmentin. So these drugs were known to them. So there we could catch them. There were various things that we taught them. What is antimicrobial resistance? What is the prevalence? What is the issue? Why we need to worry about them? Why it is called as a pandemic now? How to consume an antibiotic? How not to prescribe themselves? And how not to share the antibiotics? So all these points were addressed, and we almost took 4 5 colleges of law, MBA engineering, and we provided this kind of training sessions. Along with that, we also provided them with some educational pamphlets for them to distribute among their family members and colleagues, and so that the information spreads. So this is how we can initiate ALS at community level. Besides training on antibiotic use, this is something new initiative we started. Patients getting discharged from our hospital with the surgery, with the device, okay? All such patients will provide it with the educational pamphlet on how to care for the surgical wound, how to care for the eye after the surgery, how to care for the Foley if the patient is going with the Foley's catheter. So we provided the pamphlets. These pamphlets were multilingual in Marathi and Kannada for them to understand, and in every discharge we used to provide this. We're still doing this annually. So this particular education technique is actually helping them prevent infection at the house. So this is how we can emphasize the importance among the community. The next important core element is monitoring and surveillance. For monitoring, we have to look for the antibiotic use in our healthcare facility by conducting audits and point trial surveys. Quantity and types of antibiotics that are being used, so we can see how much is purchased, how much is prescribed, how much is getting dispensed at the unit or facility level. Besides monitoring of antibiotic susceptibility resistance rate for the range of key bacteria, indicator bacteria, and monitoring of compliance of antimicrobial stewardship intervention. This is also done as a part of monitoring and surveillance. Now we talk about the AMSP team. Who is a part of antimicrobial stewardship team? This is a long list, but never mind. The main problem is we do not get active participants. People are not willing to become a part of this particular thing. There's a lot of hard work. It's an absolutely thankless job, and so you will not find people actively participating in becoming a part of antimicrobial stewardship team. So what is suggested is we need to have an infectious disease physician, and it's a luxury to have an anti physician at your facility. So most of the time, a physician, a medicine physician can become the team member. A clinical microbiologist is a must. A clinical pharmacist is a must. Infection control professional, a quality nurse, a patient safety manager, and a hospital epidemiologist. All these have a very important role to play in AMS interventions. What is the role of microbiologist in antimicrobial stewardship committee or the team? So he or she is going to involve the antibiotic policy. She will guide the proper use of tests and flow of result and ensure availability of rapid, accurate, quality assured antibiotic test results. Create readily usable and coherent antibiotic resistant data. Guide empiric therapy by creating and interpreting facility cumulative antibiotic resistance report. This is very important because this information, if lies only with the microbiologist, it will be of no help. Clinicians will never understand what they are dealing with. So it's very important that we accumulate all the antibiotic resistance pattern and provide it to the clinicians for their use. Another important role is to communicate. Communication is the key to successful antimicrobial stewardship. If there is no communication between a microbiologist and a clinician, we will not achieve what we want to. Coordinating the facility while monitoring intervention of healthcare associated infection, and for auditing, analyzing, and reporting of data. Educating the staff and implementing strategies. So this is most important role of the microbiologist. Second is nurse. What does nurse do? Yet in our institute also we have yet not involved our nurses in the antimicrobial stewardship. The reason being they are less in number, we have more COVID patients, and they are more burdened with the basic patient care. So once we receive that, of course, we'll be involving the nurses. Nurses have a very big role to play in the AMS. They are the ones who will ensure that the culture will perform before starting antibiotic. This is more in concern with blood culture. If you're diagnosed with sepsis or clinical sepsis, in that situation, it is must that the culture sample is sent before administering antibiotics. She can question suboptimal antimicrobial management and documentation. This happens where no physician can keep or remember all the antibiotic doses and duration exactly. So it is likely that he or she can make a mistake. Even a student, even a PG or JRP can make that mistake. So like especially if she notices this, she can bring it to the notice of the physician and the correction of doses can happen. She can recognize when a patient is stable and can take oral antimicrobial so that IV to oral shifting can become possible. She will ensure timely administration of antimicrobial and follow up on this doses as applicable should be administering antimicrobial at the right rate. She will monitor the patient to ensure antimicrobial has intended effect. So intended effect, actually patient should not be having any kind of complication because of antibiotic. Suppose the patient has received vancomycin, she has developed reactions that has to be brought to the notice of the physician so that the drug can be stopped or corrective actions can be done. She can review medication as a part of daily routine. She can prompt discussion of antibiotic treatment, indication, duration of device removal. Again, she can also contribute to the stopping of antibiotic. This is something which is not seen anywhere. Once you start an antibiotic, you give the antibiotic till the patient is getting discharged. Even in the discharge summary, we provide them 5 days of oral antibiotics, whether it is required or it is not required. Half of the antibiotic that our facility provides is for prophylaxis, not for actually it should be prophylactic, but it turns into a therapeutic one. There is unknown fear of infection. That may be condition start the antibiotic and he or she will never stop the antibiotic unless the patient is getting discharged from the hospital. So this is something that she can intervene and stop. If after 7 days the patient is okay, the patient has no fever, symptomatically better, she can at least initiate a communication and discussion with her regarding whether to stop the antibiotics. Clinical pharmacist. We all know pharmacologists. We all know B-Pharm people. These are the different categories. These are doctors and they are postgraduates in pharmacy. And these clinical pharmacists have a very big role to play in the antimicrobial stewardship committee work and the teamwork. So they will be providing counseling to the patient as well as their family members regarding antibiotic use and dose treatments. They will encourage the patients to take full prescribed antibiotic. They will provide updated information on antibiotic prescribers, monitoring the supply of antibiotic and their use by patients, collaborative working of pharmacists with prescriber to order sufficient dose to complete or continue a course of therapy, and educate on proper immunization. And they will ensure that the drug does not cause any uneven problems. So here, I can give a few examples. Like in 2022, we started coming across sprays which were completely resistant to collection, completely resistant to all sort of antibiotics. We had Vitek, so the Vitek started reporting on cholesterol. Then in 2022, Vitek was actually using the UCAS guidelines to take the MIC of cholesterol, and that was still available. But none of the clinicians had any experience in using cholesterol or even polymyxin B. So initially, the things happened like cholesterol doses. Everybody started using the dose of 1 million unit. So what is 1 million unit? How it is supposed to be calculated? So that had to be like the clinical pharmacist had a great role to play over there. She was the one providing information to the prescribers how cholesterol doses has to be calculated. What is the loading dose? Loading dose was something never used by many of the physicians, not even order. So when she started providing this information, they started using loading doses for antibiotics wherever it was indicated, like for tigecycline, for cholesterol, for polymyxin B. This was an improvement happened just because the pharmacist was having a very good communication with the prescribers. Even with the polymyxin B, how are you supposed to administer polymyxin B? Can you direct polyethylene being in normal saline, or you have to use some other reagent? That was all being told by the prescriber, the pharmacist. And this is how they communicated and shared the knowledge that they have with the prescribers. Role of hospital epidemiologist. You will hardly find such a person, hospital epidemiologist, but for AMS implementation, you need to have this particular post of hospital epidemiologist, and he or she will be coordinating facility-wide monitoring and prevention of healthcare-associated infection, and to ensure auditing, analyzing, and reporting of the data, and they will assist in monitoring and reporting of the systems, educating the staff, and implementing strategies. Last, the hero of the AMS, the one who is going to actually treat the patient. He or she is going to do the majority of the work, and for that, so they have to use the standard treatment guidelines, antibiotic policy recommendation for effective management, send appropriate culture sample before starting antibiotic, follow escalation or de-escalation approach based on culture and sensitivity reports, ensure appropriate dosing, route of administration, duration of antibiotic, select narrow spectrum monotherapy drug and monotherapy drug, taper medication for IV to oral whenever feasible, and will review antibiotic conditions based on patient's situation. This is a policy made by us this year. We have been into antimicrobial stewardship since 2019. So 2021 it was made mandatory by the NAPS, of course, that we need to have a ASP committee, you need to have a policy, and that was of course the starting point for us. What does the antibiotic policy provide? So the antibiotic policy is a written guidance that recommends antibiotics and their dose for treating and preventing specific infections. This antibiotic policy is evidence-based and drafted by a committee of members. And the policy aim is to reduce morbidity and mortality, preserving effectiveness of AMA, and prevention of communicable disease. How do you prepare an antibiotic policy? You need evidence-based information. So you can use the antiparallel pattern of whole 1 year of your healthcare facility. You can also make use of national treatment guidelines. And when you're preparing the policy, you take the help of all the consultants who present the department because they are the end users. Then we have to make sure the policy that we are providing is very simple, clear, short, ideally published in small booklet for them to carry, and it should be provided to all the doctors, all the nurses, available in all wards and critical area for them to access. We can also provide soft copies in the WhatsApp. Besides providing treatment guidelines on how to treat a particular condition empirically, antibiotic policy can also provide you information regarding what is the basic classification of antibiotics, how antibiotics act. So that when you're combining two different antibiotics, you have to make sure that you are not using oral acting spectrums, you are not using two antibiotics with same mechanism of action. Right? You can make them understand what is PPPD, give a list of antibiotics which are time dependent, dose dependent antibiotics, then you can give them IV to oral switch options. Like we have experience in surgery, patient used to get treated with meropenem or present azobactam, and when the patient was discharging, patient used to get 5 days treatment with meropenem. So is it right or wrong? What we recommend is you need to shift from IV to oral. We also recommend that you should be de-escalating. When we say the word de-escalating, it doesn't mean that you remain in the same class of higher antibiotic. You have to go from higher to lower antibiotic. So providing the patient oral ferropenem on discharge was something very wrong. So this is where we can give them the option, give a list of which are the injectable antibiotics that we are giving and what is the oral option that you can give. We can also provide them information regarding which all organisms are resistant to intrinsically to which antibiotic. This whole list will help them understand what antibiotic not to ask for. Of course, systemized treatment guidelines. You can use up-to-date.com to get the systemized treatment guidelines. There are national treatment guidelines also available. You can use access those. Like WHO aware antibiotic book of 2022 also provide you guidelines regarding how to treat a patient. You can also provide some scoring system for them to understand when to start an antibiotic. I think everybody is aware of Sendor clinical scoring. Centaur clinical scoring is for identifying patients of pharyngitis who need antibiotics. Okay, so this is the commonest place where there is lot of drug abuse. ENT department, pediatric department, medicine. Majority patients coming to your OPD have pharyngitis. 80% of the infection is viral origin. Here we are treating the patient with antibiotics. So if you are using a Centaur clinical scoring, it will help you differentiate when to start an antibiotic and when not to start an antibiotic. Then you have SOFA or use SOFA for sepsis. You have curve 65 scoring. Curve 65 scoring is for pneumonia, right? So you can see mild pneumonia or severe pneumonia. So there are various points based on which you can decide where to start with the antibiotic. Again, providing antiviral pattern updated on every year is happening essential. That will help the clinician to understand what kind of organism they are dealing with, whether to start empirically with the higher antibiotic or no. So, what is the function of team? How is the team going to work? The team is going to advise on antibiotic use and will audit the prescribing practices and will implement hormonal restriction, pre-authorization, or persuasive interventions. So, how does this happen? For AMS intervention, how do we start? We are going to use two different methods for intervention. Either it will be a restrictive one, that is front-end or pre-prescription authorization approach, where certain antimicrobials are considered restricted and prior authorization is required for any clinician to start the antibiotic. For the healthcare facility should have their own list of restricted antibiotics. And majority of them belong to the reserve group, of course. Then we have the post-prescription review and feedback approach, which is a persuasive approach. Review of all current antibiotic orders are done, and if they are according to the antibiotic policy, applying to the policy, it's okay. If they are getting deviated from the policy, then there has to be a direct communication between the ALS team as well as the clinician, and we can discuss with them across the table, let them justify the antibiotic usage or selection, and if it is not justified, then we can give them the suggestion regarding another class of antibiotic. So, which one is the best and easiest one? Which is the easiest? Will it be ever possible for anyone to stop clinician from using anything? Restrictive is a dream, right? Restrictive kind of implementation is absolute dream. What you got to do is we have to persuade them. What we did, we introduced antibiotic justification forms. So this was high-end and antibiotic justification forms. What the residents or the physician had to do is once the patient gets admitted, if they have started the patient with some antibiotic, they have to fill this form. This form provided information regarding demographic details, patient's provisional diagnosis, and their suspicion of antibiotic requirement, whether you may think that the patient is having lung infection or GI infection or urinary tract infection or intra-abdominal infection, whether the type of infection is hospital acquired or community acquired, whether the patient was previously hospitalized, whether the patient has received already some sort of antibiotic. Of course, this information also helps the clinician to decide whether to go with the basic drug or go for a higher drug. So the form contains all this. So what we did is we asked the resident to fill up the form within 24 hours of admission. The next day, the pharmacist takes around daily. So she goes to the ICU ward. She checks all these forms. Then, she checks for the empirical antibiotic what we use. So down we have a table where we are supposed to actually provide with the name of antibiotic, the dose and frequency, and they'll be writing the justification why they have selected a particular drug. If it is according to policy, they just write according to the policy. But if it is not, they will put their comments on it. And these forms will then come to the antimicrobial stewardship analysis team to us. We see that if we find it justified, we stamp it as antibiotic justified. And if it is not there, then we contact, we communicate, we discuss, and we try to get some alternative. Now, once we have done monitoring, surveillance, education, we have started AMS intervention. Now we have to see actually are we aware, are we achieving what we want to achieve? So there are some structural indicators, some process indicators, some outcome indicators that we have to look into. So the main is the process indicator and the outcome indicators, whether the AMS implementation had some effect or not. Process indicator will be very simple, very easy, low hanging fruit. We can just see whether how many patients are receiving antibiotic as per policy, how many patients are receiving antibiotic surgical prophylaxis as per policy, in how many patients culture sample was sent before starting any antibiotic. This is policy adherence indicator, receiving percentages. We can also look for administrative compliance indicator. How many patients are receiving correct dose route of antibiotic? How many are receiving surgical prophylaxis within the correct time frame? How many patients are receiving renal adjusted antibiotic doses? In how many patients it is getting shifted from IV to oral? In how many patients antibiotic de-escalation is actually happening? And handover time. Handover time is something you see when the physician is putting the prescription. She is supposed to put the date and the time of prescription, and in how much time does the patient receive the first dose of that antibiotic. So this is the handover time that we are also looking at. Among the outcome indicators, it talks about the antimicrobial usage. So how do we calculate that? By calculating daily defined doses or dose of therapy. Clinical outcome indicator, what was the impact of ALSP intervention? Actually, it should identify increasing the cure rate, decreasing the mortality, decreasing the morbidity. And the last is financial outcome indicator. When you achieve this, you achieve the financial outcome indicator as well. So with this, since last 4 years, we are conducting a study which has produced a paper last month. Impact of antimicrobial stewardship on antimicrobial utilization and resistance pattern in a tertiary care hospital in Western Maharashtra. So we implemented whatever things that I told right now, and what we achieved is a significant improvement. So you can see the graph above. The numbers are daily defined doses per 100 bed days. The President Azapatnam initially was 7.7 before intervention. After intervention, it reduced to 6. Ceftriaxone, the most abused drug in a healthcare facility. We used to treat each and every dengue patient with ceftriaxone, and the ceftriaxone used to go along until the patient gets discharged. So we stopped that, and we brought a very significant reduction in the consumption. It was 23.4 initially, reduced to 6.8. With every it was 9, reducing to 5.2. In number 6.2 reduced to 5.8. Liquid solid 5.8 to 4.8. So this is what we achieved by AMS intervention. Then we also looked into the various quality indicators. The policy adherence. Antibiotic policy was something we started in 2019 actually. Okay. Then we got more number of pharmacists to monitor and do audits and all. And initial compliance with the policy for empiric antibiotic was 73%. But after intervention, like after 2022, we brought it down to 96%. Surgical prophylaxis as per policy. Now we achieve to 96%. Registered in correct dose and duration. Initial compliance 83%. Now it is to 93%. Culture based scientific therapy. Initially 61% and rising to 90%. So the first thing what happened is when we started giving, pushing the clinicians start send culture. So they used to just send culture and